Our fearless leader has allowed us to extend this session by a few minutes to make sure we have at least a couple of questions. So if you'd like to, from the back there. Yes, you.
Okay, let me just move this down. Okay?
Yes.
Oh, I guess so. My name is Iris Portney. I have a career, my question is in the context of a career on science and tech policy, and also having had experience as a survivor of a variety of experimental cancer treatments, and as a patient advocate. By the way, fabulous, fabulous discussions from all of you. But I just wanted to throw out a couple of ideas that I would hope you would also consider. It touches on many of the things that you've raised, but to kind of drill down a bit. One is the importance, well, they tie into the importance of the patient and doctor as a team. And I notice, I remember when the discussion was opened up, there was an anecdote about how patients were surveyed about what we wanted from doctors, and the two answers were a doctor who knows his or her stuff and a doctor who can explain it. I have to say, in all the 10, 15 years I've been working with other patients, what I hear over and over again from advocates is the third item is a doctor who listens, and a doctor who looks at a patient as a source of information to help that doctor do a better job diagnosing and responding. So in that context, I think it's important for doctors to encourage patients to review patient notes for accuracy. Because however wonderful data is, if it is not accurate when it goes in, then all the way down the line, as with a bad, an erroneous credit report, it just gets pushed on further down the road. So it's not enough to tell patients that you can look at your data, at your notes, but to please ask them to, if they can, and be able to correct that. Secondly, so that's an opt-in or an opt-out on that. And secondly, I would love to hear the thoughts about what's going on in your thinking about the potential of big data in terms of being able to get information from a wide population about responses to treatment, responses to symptoms, diagnosis, et cetera. And in this context, I'm thinking of the current model being developed by the ASCO, the American Society of Clinical Oncology, and their CancerLink plan, which is designed to allow doctors in the clinic setting to be able to input in real time what's going on, and also be able to track and find out information that's going on beyond simply clinical trials. Okay. And other treatments, because that seems so exciting.
Okay, let's see if any panelists want to say anything about big data.
Wow.
I can make a few comments. In spite of the hype, I think there's something behind big data. And I was a few years ago in Australia, and Australia has a healthcare system that should be the envy of the world in terms of data. They were one of the first countries to establish EMR, and they have very good patient records and statistics, so they can do things in public health that we cannot do for lack of integration of our system. So big data is interesting because a lot of conversations now are around best practices and even FDA clinical trials. And when you have enough data, enough public health data, you can actually streamline clinical trials and make them safer, because you can try something on the system and quickly react and respond to it, something we cannot do. So clinical trials are extremely onerous the way they are now. So my comment is, it is something that we in healthcare should pay a lot of attention to, and I have a few examples, but I don't want to extend, but I would like to invite you to look up two things on the web. One is a company called Massive Health, and they have a simple iPhone app called The Eatery to help people improve their diets. And there are a few amazing lessons in big data in that app. And the second one was a company that used to be called Asthmapolis. They make a little holder for your asthma inhaler, and they collect two simple data points. They collect when you use your inhaler, asthma rescue inhaler, and they have a GPS, talks to your phone and collects information about geography. Two very simple data points, but when you have a large enough sample of users using the system, you can tell people amazing things. For instance, times of the day when you had your asthma attack. So you can report true data to your doctor, not when your doctor asks, every 3 months, how many times have you used your rescue inhaler? And the patient, I don't know, maybe 17, right? So now you have data. And also you can tell areas on the city that are more likely to induce asthma in people who are susceptible to it. And you can find data about yourself. Every time I buy groceries at the supermarket, I don't feel well. So big data is an amazing thing in terms of self-knowledge and ability for us to learn about public health that should be leveraged.
Thank you. We'll have time for a couple more if you can keep them short.
My name is Toby Levin, and I'm chair of the Patient Family Advisory Council at Suburban Hospital here in Bethesda, which is part of the Johns Hopkins system. And I now enjoy having my health information with 3 different providers on 3 different portals, which don't speak to each other. Short of my establishing my own private health record on yet a 4th portal, which I would have to pay for, I would like my 3 portals to speak to each other. How are we going to make that happen?
Yep.
Farzad, you spent a fair amount of time working on that one.
What's that?
Well, first of all, there's the comedian who talked about Wi-Fi on an airplane, and how something that before seemed amazing and incredible, once you actually get it, you're like, wait a minute, this damn thing isn't working, right? So partly this is it's a good problem to have, that we now have portals where we can actually see our own information much better than before. And I do think that the patient can be what breaks through oftentimes the business interoperability problems that we have. We do now have standards for how medications are coded, diagnoses are coded, how that information could be packaged. A lot of the lack of information sharing that's occurring is because, maybe Hopkins doesn't necessarily want GW or MedStar to have all the information.
No, it has to do with the way the HITECH Act facilitated proprietary creation of different systems
Of course.
that don't speak. It's not the hospital's fault.
Of course. So there are business interoperability challenges that underlie, both at the vendor level and at the provider level, the lack of data sharing. But I do think that the one group that can cut through all of those is the patient.
No, I don't want to make a full-time job of my having to manage those electronic records. It's the government. I'm sorry, I think you missed a key opportunity to make it all interoperable. And your blue button idea, which is great, isn't the answer either.
So one anecdote about EMRs. I had a recent conversation with a developer, and I said, why are EMR systems so bad? He said, they are not bad. I said, yes, they are. Doctors don't like them. And he said, jokingly, the doctor is not our client. Our client is the hospital administrator who wants to make sure that no procedure, however small, goes unbilled. So that's what they are designed for.
Yes, sir. Last question.
I'm Martin Avoitis. I'm with HealthJump, a patient-centered health exchange. Question is, I would like examples and in how data, as the lady spoke before, how patient data can be looked at by the patient, where this has been successful, and how successful in cleaning up the data, and how we can work on this issue going forward so that patients are more involved.
So the question is where patient access to data has been successful, how they can clean it up?
Successful in cleaning it up, yes.
Yeah.
You want to talk about open notes?
Sure. I actually start with that HITECH Act missed opportunity. One of the things that was in the HITECH Act was that patients not only have access to a portal, but they actually be given a copy of their records. And that's part, the after-visit summary that I'm sure a lot of doctors, complain about. Why do I have to do this? And one doc said to me, every time I'm handing these out to the patients, and like all the time they're coming to me and saying that, the information on there is wrong. And I love it because I get to correct the information in my records. That doctor was unusual in his loving it. That it was an opportunity to correct, although that is actually one of the rights under HIPAA. People don't know, is not just the right to have your information, but the right to submit corrections and amendments to it. The bigger problem, honestly, with a lot of the patient-centered information exchange, aggregation, correction, data quality stuff is the point that was made. People don't want to make that their full-time job. And I think what we need are proxies, people who will do it on behalf of you, solve problems on behalf of you, for you, to help you. And I think the big missed piece here is we don't have a HIPAA for those other non-covered entities that would be in the best position possible to help curate your information and generate meaningful insights for you. And because of that, some of the people most situated to help you with that, the internet companies, are shying away from actually being that agent for people in accessing their information. I think that's going to be something, if there is one legal change that I think can help with that, is clarifications around privacy policies for those non-HIPAA covered entities to help people with that.
This is an issue I actually do have a little experience with, and I understand your frustration with the business models of the internet companies, but it's actually not right to say it's not a provider issue. As someone who is involved in the original, now much lamented Google Health effort, which was trying to create a way in which Google, like Microsoft Vault and others, could aggregate and display for patients information. The problem was at first patients weren't going to populate it, and second, providers did not want to give up the data to some other entity. So there are a number of issues, from business models of EMRs to the state of technology to HIPAA. I guess I would say I'm a little optimistic, in part because this issue of interoperability is now clearly on the policy agenda, and there are a lot of points that have been made about it. And second, sooner or later, if there are more and more people who are mad like this, someone will come along who will figure out a way to abstract the data. As someone who's a Kaiser member, I gotta say the Kaiser display used to be lousy, and now I love it. So these things do get better. Sometimes, as you say, the fact that we're hurtling across the country at 5,000 miles an hour, 30,000 feet in the air, and we're concerned about how fast our Wi-Fi is. Yeah, it's frustrating, but I'm optimistic that these things are getting better. Join me again in thanking our great panel and turning things back over.